So, after prostate cancer diagnosis and or treatment, who's the right candidate for testosterone replacement therapy or TRT? Is it the men on active surveillance? All right. How about men on active surveillance or men who've been treated for prostate cancer and now have a recurrence? Men with advanced disease, even after ADT, are they a candidate for active surveillance? Today's guest is Dr. Helen Bernie from the University of Indiana. She's a board certified urologist and director of the Male Sexual and Reproductive Medicine at Indiana University. Dr. Bernie is the assistant professor of urology and an andrology fellowship, and she completed a 6-year urology residency at the University of Rochester and completed a fellowship in male sexual and reproductive medicine at Memorial Sloan Kettering. Dr. Bernie is an active member at the International Society of Sexual Medicine and the Sexual Medicine Society for North America and sits in the board for the SMSNA. We went through the whole spectrum of why should we treat men after prostate cancer with TRT, and who's the right candidate to treat with TRT after a prostate cancer diagnosis. My conversation with Dr. Helen Bernie on all things testosterone treatment after prostate cancer. Let's go. Welcome to the Dr. Geo podcast. I am your host, Dr. Geo, where it is my goal and my intention to help you improve and optimize your prostate health and how to live better with age. Today we have Dr. Helen Bernice. I always kind of butchered your name. I'm sorry. Bernie. Dr.
Bernie.
Helen Bernie. Why did I call you Bernice? I'm sorry about that, Helen. We've been talking on a first name basis as I've met you. Hey, thanks so much for being on. It's such a pleasure. You're out there in Indiana. You're not from Indiana originally, are you?
Oh no, born and raised in Sweet Home, Alabama.
Right? Oh. Well, no more Saban, no more Nick Saban for you guys.
I know.
I mean, God, look, what is it, 17 years or so he's been with the
17 years. Like I remember it exclusively when he started and we were all so excited. And then he just created this empire.
Right. He's great. He's put Alabama on the map quite a bit. I hear kids in New York, kind of saying, yeah, I'm going, where are you going to, yeah, I'm applying to Alabama. I was like, whoa, it's a big deal. So I think a lot has to do with football and notoriety the team has brought to the school. Helen, you bring a lot of interesting things to the table. And we're certainly going to get into the conversation of testosterone in prostate cancer situations. But as our audience will know from the bio, you are a male reproductive doctor and you're a female. I mean, you treat erectile surgically and with pharmaceuticals. You treat Peyronie's disease. I mean, and I always find it interesting when there's a male gynecologist. I know they exist, right? But I'm like, what got you into becoming a gynecologist? I'm just curious, right? So I have to ask you that question. I mean, like, what got you in being interested in male reproductive systems? And that's exclusively what you do, I think.
Yeah, no, great question. I get asked it a lot. I think, with almost anything in life, when you start to take a step back of how did you end up where you are, it's almost always due to, something sparked your interest, some experience, some mentor that you met that really starts to show focus in you and time in you and invests in you. And you just start to realize that, hey, this is stuff that I really like. I feel really comfortable talking about this stuff. For me, I really love men's health because number one, not only do I get to dramatically improve patients' quality of life, but I can improve their overall health. I like to think of myself many times as like a primary care doctor inside a surgical subspecialist. So when someone comes into my office, men don't go to the doctor, right? So they come in for one of two reasons, sex or fertility. And once I get them in the door, then I can talk to them about their diabetes. If we're not controlling those sugars, you're not going to be able to get an erection. You're not going to be able to ejaculate. You're going to lose your eyesight. You're not going to be able to see your partner. And I can really counsel them. And I actually have a lot of motivation behind that. I can talk to them about quitting smoking. I can talk to them about getting their lipids corrected and making their cholesterol better. So I love that. And I really thrive on that because I feel like not only do you get to get into their intimate lives and really improve quality and bring intimacy together with their partner, but you also get to dramatically improve their overall quality of life. And that's something that's really
you're preaching to the choir, right? This is the role. This is my role at NYU, where I get to kind of treat the person and not so much the disease a little bit. And from a holistic perspective, and looking at the interrelationships of the different systems and things like that. And that's right, LDL and cardiac workup. If a guy doesn't get a erection for 3 months or so, it's like, well, red flags, right? It's like, what else is going on? Is a blockage perhaps somewhere else?
Exactly. And we know that erectile dysfunction precedes cardiovascular disease by 3 to 5 years. So as gatekeepers of men's health, being urologists, this is really like our job to be able to catch these things early, to prevent things from happening and improve overall health, as well as treat the issue that they're.
Well, I'll tell you, Indiana University is lucky to have you. You are a foremost expert in the field of male reproductive, but I certainly think you're one of the top, certainly females. How many females do male reproduction that are urologists, you think? I know there's one at NYU. How many are there now?
So good question. In the field of just urology in general, only 10% of women make up urologists across the country. And of that 10%, a large majority are either in pediatric urology or FPMRS, which is female pelvic and reconstructive medicine surgery. So I don't know, but it's not many. We have a wonderful female sexual medicine expert, Sharita King, who's down in Georgia. We have Mara Heyman, who's at University of Washington. We have several people that, Denise Safuaje, who's at Chicago, Loyola. So, I mean, we're scattered, scattered.
When I go to the AUA, I see that there are separate meetings, like female urologist meetings. Are there female male reproductive meetings at the AUA, or is that happening slowly? Yes, not that many yet, but I can see you. I can see a light bulb on your head there. I think knowing you a little bit, you're probably thinking of one.
I'm hoping to put something together at our next Sexual Medicine Society of North America meeting in October. So put something together. But many of the industry companies like Boston Scientific or Coloplast, they do hold specific events for like women in prosthetic urology and women in sexual health. So they do a lot of nice events for us to get together and to collaborate and really talk about thoughts together.
And as luck may have it, you have 3 children and they happen to all be boys. You have 3 boys.
Yeah.
So, it's unbelievable. It really is. It's like, wow, who would have thunk it, right? So my sister-in-law is a pediatrician. And so when one of her kids has like 100 fever, you would think she knows what to do. No, she'll take them to a pediatrician. So do you look at your boys that way? Do you examine their testicles, look for odd things? I mean, they're still young, so it's still probably not an ED such scenario that you have to focus on. But is there any of that? Like when they were born, obviously when my son was born, I made sure that his testicles were descended and things like that. So how are you with your sons and checking them out, making sure that they are okay?
Well, not only am I a urologist,
he's not a male reproduction guy, is he? No.
No, he does general urology, but having a household where you have 2 parents that are both urologists, our poor kids, man. But no, in all honesty, our middle son had something called retractile testicles. And that's where they have a hyperactive cremaster muscle reflex that pulls the testicles up. And his just tended to stay up more often than they were down. And by the time I had my 3rd son, I was like, his scrotum is bigger than my middle son's scrotum. So we need to do something. So we actually had to get him, he had what's called an orchiopexy, where they tack down and pull the testicles down so that they stay down, which is actually really important for men, because if they have undescended testicles or retractile testicles that spend a large majority of time up, you can actually impact fertility and testosterone.
So in retracted testicles, so the testicles are in the scrotum. The muscles around the scrotum are called the cremaster muscles. So they are in the scrotum, but it tightens up for reasons that we don't know, and it gets too close to the body. So the idea is the idea of that nature, God, whatever your beliefs are, is that, the testicles are, separate and away from your body because it's like what, 2 to 3 degrees difference in temperature,
Mhm,
two to
2 to
four.
4 degrees. So the body, the cream esters are meant so that they regulate body temperature. So they relax more when it's too hot and they pull them in more, like if you're in a cold environment or you jumped into a freezing cold water. And so it's a temperature regulation, just like you said, to help with the production of sperm and testosterone. And they do need to be 2 to 4 degrees cooler. So me being a reproductive and sexual medicine doc, I was like, if we don't fix this and my son has
Right,
issues with
right.
fertility, I'm going to blame myself
So what's
forever.
the procedure? So these are retracted muscles that never relaxed.
Or very infrequently, like they keep pulling up and staying
And what's
hypercontractile.
you don't have to be graphic, but I have a son, and I do some male reproduction. So I've looked at him and I look at him still to just make sure, what am I looking for? Like, does it look like when he comes out of a, cold swimming pool like that and when it's kind of all wrinkled and squished to his body, but it's always like that, even when the weather is warm? Is that kind of what you're looking for?
So for us, they were all still pretty young. Like my middle son had his orchiopexy, or where they brought it down when he was 3. So they were still like in diapers and pull-ups. So when I would change them, I just started noticing that I really didn't notice them. And because if they're in a warm bath, you should see testicles in your son. And if they're even in a warm, nice bath and you're not noticing when you're helping clean and bathe them for the evening for their nighttime routine, that should be a sign to maybe just go get it checked out, take them to their pediatrician. Me being a urologist, I reached out to our amazing pediatric urologist at IU, and I was like, "Can you
Right.
take a look at my son, please? Because I don't want to be that crazy mom that
Right.
like is over assessing their kids, but like I think
Wow,
something's
that's
going on."
great. Well, thanks for sharing that personal note. I think that will make it, that alone will make it interesting. This conversation, this podcast episode, to be a hit. All right. So I had a brief conversation. Well, I had a whole podcast with our colleague and friend Mohit Kara, who's a renowned expert in testosterone and male hormones.
Wonderful physician.
We dabbled and touched a little bit. We had a whole full conversation on testosterone and the prostate, and then of course we talked a little bit about prostate cancer, but we didn't focus on it. So that's what I'd like to do with you, because I know that you treat men who are hypogonadal or have low testosterone with TRT, and you treat men with a history of prostate cancer with TRT. And still, this seems like to me a little controversial, although it shouldn't be at this point, but people are still hesitant, I find. So take us back to, why do we think that testosterone is the fuel for prostate cancer, where prostate cancer develops and progresses? And we'll start there. Take us back, Huggins days, 1940s, if you'd like, and where we come from since then.
Yes.
So take it away.
So so brilliant, you already know. So we literally got this idea that testosterone is like gasoline on a fire for prostate cancer by this one physician named Dr. Charles Huggins. And he wrote this paper back in 1941 on studies on prostate cancer. And it was actually published in, I think it was
Mm-hmm.
Cancer Research was the magazine. And he was even awarded the
Mm-hmm.
Nobel Prize in 1966 for his
Mm-hmm.
research in this, which concluded that cancer of the prostate is activated by testosterone injections. Now, if you go back and you look
Mm-hmm.
at that study, the interesting thing that we see is that all of it was actually based on
Mm-hmm.
one patient. That's right. The entire premise that testosterone is bad in men with prostate cancer is based on a paper in 1941 with one
Mm-hmm.
patient's results. And from then on out, testosterone was terrible. It's the devil. Don't use it. And it perpetuated this, 50 plus years of men really having to suffer and have terrible quality of life because we felt that we were going to hurt them. And, thank goodness to a lot of groundbreaking research from Dr. Abe Morgentaler and others in the field, we started to finally get data that showed, what, maybe our initial understanding of testosterone and prostate cancer wasn't exactly the
Mm.
same.
And so, yeah, you're right. A lot of men suffered. They were probably, low testosterone. They had, like many men, as they get older, they become hypogonadal. And there are ways. There are natural ways. I hope to speak on that at the next SMSNA meeting, the sexual health meeting next time. But in my world, I love TRT because you know what? I'm asking them to do A, B, C things. Like, hey, let's improve your sleep. And sometimes they're so down and out that let's get you on some TRT, and then eventually either stay on it or figure out how to wean yourself off if that's what you want to do. So we've come a long way with that. So we know that in men who have never been diagnosed with prostate cancer, that testosterone doesn't fuel it or doesn't start the development of it. What I think I know based on the research that I've read, and you can correct me if I'm wrong, is that the opposite may be true. In other words, low testosterone levels in men are correlated, well, not causation, but correlation with high risk prostate cancer. What can you say about that?
Yes. So PSA, or prostate
Or
specific
patient
antigen,
stimulated
is
anxiety, but
secreted
go
by
ahead.
exactly. I like that. So it's secreted by cells in the prostate, right? Every man has a prostate, and it secretes PSA. Well, what is cancer? Cancer is just the rapid multiplication of cells, right? Or growth of more cells. So unfortunately, while PSA is not a perfect test, it's one of the tests that we use to look for prostate cancer in men. So PSA is an androgen dependent molecule. That means that you need testosterone in the body in order to make PSA. So in men that have low testosterone, you may have falsely low levels of PSA. We have many studies from where I did my fellowship at Memorial Sloan Kettering and other great oncologic institutions in the country that have looked and found that, just as you mentioned, low testosterone levels are actually correlated with higher rates of prostate cancer, more advanced prostate cancer tumor grade, stage, and volume compared to eugonadal men. And we even have observational studies that suggest that men taking testosterone do not have increased risks of developing prostate cancer. And so, I'll talk to you about some of these studies too, and happy to. But I think, more and more we're actually seeing that perhaps in the future, when we're screening men for prostate cancer, or in even following men that already have a history of prostate cancer, we shouldn't just be getting a PSA, but we should also be getting a testosterone, because we could see a falsely low PSA just because these men are hypogonadal.
So I had Neil Shore on. So I don't know if you knew him, Neil. He's a urologic oncologist from South Carolina, prostate cancer expert, but particularly advanced prostate cancer expert. One of the few that's not a medical oncologist, a urologist. Had him on, and I said, Neil, when are we gonna? When will the time come where androgen deprivation therapy is not a treatment? There's something else better, because these guys. Well, I have to say, in my homogenous group, so these are men that are on ADT, but very proactive. They pretty much do everything I ask them to. They sleep, they train, they exercise. So their quality of life, it's not horrific, but they're having sexual dysfunction that no one can do about, right? But by and large, I've seen many men, and you've seen them, who are in ADT, and they don't feel well. I mean, they feel pooped. They feel pooped. So I asked him, and he sort of was unsure of that, though he understands. So my question to you is, as best as you know, and I know you deal with primarily mostly benign male reproductive issues, why is ADT a treatment when we know that testosterone is not the fuel for prostate cancer? Why chemically castrate? I wonder if you have an answer for that.
So there was a really good paper by Samuel Denmead, I believe, and John
Hopkins.
Isaacs, and I hope I don't
Yep.
botch it up.
Mhm.
Yes, from Hopkins. And they wrote this paper, and it was on the bipolar androgen therapy, the rationale for like rapid cycling of super physiologic androgen or ablation in men with castrate-resistant prostate cancer. And the major problem that they talked about, in this approach with men, was that most men who receive castration therapy, they don't rapidly return to eugonadal levels of serum testosterone once you
describe
stop
eugonadal levels for our
therapy.
audience.
Oh, good. Sorry. So they don't return to regular levels, and regular defined is typically a testosterone level between 300 and 900, depending on which lab, or 300 to 900 nanograms per deciliter of testosterone. So typically we say someone is hypogonadal if they're less than 300. And typically when we're treating prostate cancer, our goal is to get a patient castrate, or that means below 50. Now, men that are below 50 will tend to exhibit many of the symptoms that we see in women that are postmenopausal, like hot flashes, night sweats, all of these, decreased energy, low sex drive, all of these similar symptoms. And in fact, men that have testosterone levels less than 150 usually can't ejaculate or orgasm anymore. So testosterone is really important for sexual health as well. But, we see that if these guys, most of them won't return to these normal levels of serum testosterone after you stop the castration therapy or the androgen deprivation therapy. Typically, it can take months or longer, particularly in elderly men, or sometimes it just doesn't come back at all. So, just as the prostate cancer cells have time to adapt to these, intracellular testosterone levels or androgen receptor levels, these cells have an adequate time to readapt, in response to an increase in your serum testosterone that can occur over months.
I'm super excited about today's sponsor, which is Mr. Happy XY Vigor, a formulation to enhance testosterone levels and promote sexual function. Mr. Happy XY Vigor, or XYVGR, was formulated by yours truly to optimize male hormones and free up testosterone and improve sexual health. It also has an abundance of L-citrulline, which helps dilate and open up blood vessels so there's more circulation going into the pelvic area for better erections. Try Mr. Happy XY Vigor today at immrhappy.com/products/XYVGR.
So, while there's, some people give it all the time, some people do intermittent androgen withdrawal. Some people actually, I think there's some new data even suggesting giving testosterone to some metastatic and pulling it back.
Well, that's Dr. Demid from Hopkins, who's doing this bat trial, and I'm trying to get him on as well. It'll be a very interesting conversation. Because a lot of this is a question that's commonly asked, right? So why, if it's not a problem, why castrate?
The thoughts too behind it is that, just like in normal physiology of any hormone levels in our body, basically it's going to allow for your cells to adapt to the environmental conditions. And so lots of different things. I'm certainly not a urologic oncologist.
I've had Alicia Morgans. We talked about it a little, and from Dana-Farber and Rana McKay, and we touched on it a little bit. But I figured that ask the testosterone expert for her opinion, which is you.
The other goal when people give androgen deprivation therapy is that we do have data that shows when you give someone androgen deprivation therapy or Lupron, it works synergistically with radiation therapy to help target prostate cancer cells. So by shrinking them or depriving them, the radiation is able to better target it and have a better impact and effect on the prostate cancer. So a lot of times, really the data is because it's going to work because most of these patients aren't just getting hormone therapy alone. They're also getting radiation therapy or some combination therapy.
All right. So we're going to take it through the different stages of prostate cancer, and we're going to talk about yay or nay as it relates to testosterone treatment in men that are hypogonadal. So the one group that we can talk about is the low risk group. So they've been diagnosed, they're in active surveillance for prostate cancer. They have a Gleason 6 or Gleason grade 1 prostate cancer, and they're hypogonadal. So two questions with that. One is, do you treat numbers? In other words, if they're only below 300, or if they're showing signs and symptoms, but their numbers are, 350, 400, would you still treat? And how will that affect their Gleason 6 prostate cancer, if at all? Take it away.
Great question. So in men that have very low testosterone levels to begin with and low PSA, and let's say they have low risk or active surveillance, like you mentioned, if you treat them with testosterone, you may see a little rise, a little bump in that PSA initially, because now all of a sudden you're giving them testosterone therapy. PSA is an androgen-dependent process, so now it's getting testosterone and the prostate cells can make PSA. You see that little bump, but it plateaus. And that's something called the saturation model that actually Dr. Abe Morgentaler also came up with. And in that it was that once it reaches a certain level of testosterone, which is typically 250 nanograms per deciliter or more, and that's even hypogonadal, right? 250 is below our 300 threshold, that you won't see that bump in prostate cancer. So for me, when I have a patient that comes to see me, I talk to them about risks and benefits, if they have a history of prostate cancer, of being on testosterone therapy. And we actually have some great AUA or American Urological Association guidelines that came out in 2018 to give us some guidance on what to do in these patients. Number one, we let them know that there's an absence of long-term data to show a risk-benefit ratio in men that have a history of prostate cancer taking testosterone therapy, and that there's an absence of long-term data looking at the safety of testosterone therapy in prostate cancer. That said, I look at guys, if they are symptomatic, if they are feeling terrible, I will treat guys that have a total testosterone level of below 450 because we know that in men and women, testosterone levels are highest in the morning, right? And that's when we tell people to get testosterone levels because we want to know what's their best testosterone, because if that's low, we know it just goes down from there. So we ask them to get morning levels. If your morning level is 350 or 400, by the afternoon, chances that you're hypogonadal are pretty high, and you're spending the rest of your day in a hypogonadal state. We know that testosterone levels drop about 30% within the first hour of a man waking. So based on that data, I will treat them if they are symptomatic and if their testosterone levels are less than 450. I don't have a strict that they have to be under 300, because what does that say about the person who's, my total testosterone level is 310? I mean, is that person not going to feel hypogonadal, feel awful at the end of the day? And we have a wide range of normal testosterone levels, right? And the AUA guidelines recommend treating in a mid-tier, so getting it between like 450 and 650 or so.
Okay, great. So when would you pull them off of testosterone? What is the scenario? Again, Gleason 6 guy, active surveillance. At what point would you pull them off? What are the signs or symptoms or signals or lab reports that you say, okay, we need to take you off?
So very good question. If they started to have a rising PSA, we would recheck it in about a month. And if it continued to go up or showed it was consistently rising or it didn't drop back down, I would refer them to their urologist who's managing their prostate cancer. And then we would all make a shared decision about what the next steps are. I say that because I do have some high-risk guys, and we could talk about this too, but I have some high-risk guys that have actively rising PSA that tell me, doc, I've had a radical prostatectomy. I've been on ADT therapy before. I had radiation therapy before. I'm not going back to that. And so, then you have a whole different conversation with these types of patients, because there's something about death and dignity, right? Of letting someone make that choice, because sometimes it's not always about it's not always about quantity of life, but more so about the quality of your life.
Absolutely. And it's empowering, right, to the patient that they're in the decision making of what happens to their body, as opposed to, well, the science strictly shows this. I think you and many others do it, in such a responsible way. It's a shared decision process, right? So hold that thought, because we're working our way up to more aggressive prostate cancer in a second. So in a patient with active surveillance, PSA goes up, they probably have to rebiopsy, and then at that point, determine.
We would make a decision. So if the next step was to undergo prostatectomy or some treatment, we would hold off on all testosterone therapy. And then I would consider restarting it if they're 12 weeks out after their treatment, whether that's radiation therapy or radical prostatectomy, and they have an undetectable PSA.
Great. So that is the next patient example. This is now a patient who, prostate cancer, some sort of intermediate risk of some sort. Well, actually, in the patient that's been treated with prostate cancer, when would you say, again, so it's all localized based on imaging, but, we have Gleason 7, whether it's 3 plus 4, 4 plus 7, Gleason 8 or 9. What's the scenario there? They're hypogonadal. They are symptomatic. They've been treated with either surgery or radiation. Which patient population and how long would you wait before you say, okay, yeah, we can get you on TRT? Or which patient population is like, Gleason 9, I'm not doing it?
No, very good question. So there's really no one that I wouldn't consider it on, assuming that they're not currently being started on ADT, obviously, right?
Yeah, they're not started on ADT. We're not there yet. That's the next patient example.
But in someone like this, again, after they've had treatment, I would wait 12 weeks, which is typically 3 months when we get the first PSA after treatment, and assuming that it's non-detectable. If it is currently rising or it is detectable, again, I hold off at that point, because they're still in discussions with their radiation oncologist or their prostatectomist about what are we going to do? What are we going to do with this rising PSA? If the plan was, okay, you have a little bit of a rising PSA, but we're going to do nothing right now, I typically tell these guys, let's maybe hold off another 3 to 6 months and let's see what's going on first and what's going to end up happening with their prostate cancer. And the patient that, as we already talked about, whether it's intermediate risk, low risk, active surveillance, had treatment, undetectable PSA, I would start them on testosterone therapy after a shared discussion about risks and benefits of being on it. If their PSA starts to rise, I'm going to repeat it in 1 month. If it's continually rise, we'll get all parties involved, whether that's their radiation therapy or a prostatectomist. We'll talk about it. If patients are like, you know what, doc, I don't want to, stop this. I feel great. I want to do this. I allow them to do that with close follow-up, assuming that they're of sound mind and body to make their own decisions about their quality of life.
So
and their
this is
outcomes.
despite, so we talking Gleason 9 again. There's no, they just got a prostatectomy, Gleason 9. You're going to wait 3 months, get their first PSA. I don't know. Do you look at margins? Do you look at their risk? So they got a Gleason 9 localized, but some indication, maybe genetic testing is showing, well, there's a probability of, risk with regards to recurrence, let's say. How does that all play a role here?
So really good question. Again, I'm going to wait. I'll get their PSA at the 12-week, 3-month mark. And then we make a shared decision making. I actually, when I was a fellow at Memorial Sloan Kettering Cancer Center, we did a large study looking at a group of over 1,500 men who had all had radical prostatectomies. And we divided them into groups of low risk, intermediate risk, and high risk prostate cancer. And then we looked within each group. So within low risk, those that had normal testosterone, those that had low testosterone that we did not treat, and those that had low testosterone that we gave testosterone therapy to. We did this for all groups. So this included high risk groups, and high risk are, again, your Gleason 8 and above, positive margins, positive lymph nodes, positive seminal vesicle invasion. And we looked at the ones with normal testosterone, those with low testosterone that we did not treat, and those with low testosterone that we treated. And we actually found that in patients with even high risk prostate cancer with low testosterone that we treated, so low testosterone on testosterone therapy, they had no higher rates of or time to biochemical recurrence than men that had high risk prostate cancer that had low testosterone that we didn't treat. And in fact, it actually showed a protective effect, meaning they actually took a little bit longer before they had biochemical recurrence than the patients that had low testosterone that weren't treated. It was just too small of a sample size to reach statistical significance to say it had a protective effect. But we're not the only study that looked at this. There's been several published studies by Faisal Yafi's group out of UC Irvine, by Abe Morgenthaler's group, Memorial Sloan Kettering, John Mulhall, many that have actually shown that, when you give men that have prostate cancer testosterone therapy, not one of the studies out in the literature now, not one of them shows that there's an increased risk of biochemical recurrence in this patient population. So I think that says something. So again, when I see patients that have high risk, I have a discussion with them. And I have a patient right now that I can think of because he's my happiest patient. He loves me. He's my nicest, sweetest patient. And he had metastatic prostate cancer and he's on testosterone therapy. And I follow him closely. And he tells me every time I see him, Doc, I've never felt better in my life. I have more energy. I'm able to walk from the parking lot into the building, whereas I used to be winded or tired. I'm having great intimacy with my partner. And he tells me, my dad and my brother already died of prostate cancer well before my age. And if I die tomorrow, Dr. Bernie, I'm going to die a happy man. Now, he's obviously an older man, and I've actually gotten permission from him to give grand rounds and talk about him. So he's a wonderful patient who is just a huge proponent that talks about quality of life over quantity of life. And I think as physicians, sometimes we forget that it is a shared decision making because we always want to help treat people and we always want to cure people and do no harm. But sometimes helping people is actually improving their quality of life and not the
And who's to say
life.
that you wouldn't improve their quantity of life as well? We don't know.
Right. Absolutely.
Right?
Absolutely.
All right. So you're saying that as a whole, we're not practicing evidence-based medicine.
Not when we tell people that you cannot have testosterone therapy because you have prostate cancer. We shouldn't be paternalistic and tell people they can't. It really should be a shared discussion, shared decision making based on the data that we have and using the guidelines available to us.
All right. Okay, so we got the guy that has been treated for prostate cancer. You treat them based on all these parameters 3 months after treatment or a year, assuming that everything is clear.
As long as if they want to be on testosterone therapy, they have low testosterone or less than 450 symptomatic, I will offer them testosterone therapy if they want it. If it's been 12 weeks and their PSA is not currently rising.
And then if it starts rising on TRT is discussion with the team, his healthcare team, his oncology.
I'll repeat the PSA on anyone. I'll repeat it 1 month later, because maybe it was just a bump or a spike or they got a prostatitis or they had a Foley catheter for some reason, things that can increase PSA. And if it's stable, great, we keep them on it. If it's rising, we do a shared decision making with everyone involved, all on board. And if the patient still at that point in time is like, look, I understand these risks. I understand that, hey, we don't have enough data. Maybe it will hasten my prostate cancer. Maybe it'll make it more aggressive. Maybe I'm going to die sooner if I get on this, but I would rather feel good being on this because my symptoms without it are this bad, then I'm okay with letting them be on
Wow, I
testosterone
love it.
therapy. And I document it in my
All
notes.
right, patient with advanced disease. I mean, the Gleason 9 guy from the second example is considered advanced, but this is a case where we know that it's not localized. We know that it's on a lymph node or perhaps even bone metastasis. You already told us about an example of that. And they've been on ADT or are on ADT. So what's the scenario where they are on an anti-androgen, whether it is whatever, I mean, Vix or Lupron or enzalutamide, or they've been in it on this treatment for prostate cancer, advanced prostate cancer, or they currently are. So give us an example. What would you do from a testosterone perspective? We know that BAT is not yet, approved to do. So this is bipolar androgen therapy, not yet approved. So what would you do in that scenario? And at what point would you say, yep, it's okay to give them TRT?
So you're talking about the patient that is currently
so
on
both
androgen
on
deprivation
ADT,
therapy?
and I know that's you can talk about that. I know that's not completely your call, and or now they are off of it and their PSA is undetectable for however long. What's your thinking in those two scenarios?
So if someone is currently on androgen deprivation therapy, I do not start them
Right.
on testosterone therapy because it's defeating the purpose. Why are you taking one therapy and you're, wanting a different? So that would be a no for me. Someone that just came off androgen deprivation therapy, we know that some men, your testosterone levels are going to rise. We did a study again when I was during fellowship where we looked at this and we found that so we know that some patients that we give androgen deprivation therapy to, their testosterone levels are never going to come back up to normal levels. But we do know others, they will come back up to normal levels, even if they don't come up to baseline where the patient's testosterone therapy used to be. I typically tend to wait at least 6 months after they've completed androgen deprivation therapy to give time to see if their testosterone levels are going to come back up to a normal range and they're going to feel better. And in the meantime, I talk to them about lifestyle modifications and things they can do to help them with energy or whatever their symptoms are.
So the scenario I'm in is that with either herbals or lifestyle or both, they're coming to me, this situation, high risk prostate cancer, they were on ADT, they're off of it now. And they're saying, what can you do to help me, optimize my T levels? Shared decision, a sign here, sign there, but would you have any concerns with, I know lifestyle, if I ask them to lift weights and do certain things and dietary things, but I'm also giving them some herbals that seem to work. I mean, there's nothing works like TRT. My audience knows that TRT works. But if they're willing to kind of go in a little bit slower, there's some herbals that may work. We can talk about that offline or some other point, my thoughts on that. Would you have any concerns in that regard?
No, I usually, because that's a common thing. I'm sure you see it way more than me, but I'll have patients come in, they'll say, Doc, what about saw palmetto for my prostate cancer? Or what about this? And I just let them know that, we don't have any randomized controlled trials that show that it's a benefit. Some trials we do have that show maybe it's no better than placebo, but I say, there's no long-term evidence on it, but if you like it and it's not hurting you, sure. I just let them know that, it's not FDA approved or we don't have data on it.
But strictly from the perspective of they're doing A, B, or C herb to increase their testosterone, assuming that's playing a role in it, you don't find it to be, because this is the area that I kind of struggle with a little bit. If they've been on ADT, and of course I wouldn't want to do anything to promote, and there's this very similar discussion, quality of life and things like that we talk about. You wouldn't be concerned?
I don't think so, no. Because again, it's their natural testosterone level that you're trying to raise, right? The things you have to worry about are these over-the-counter boost things that maybe actually probably have some real testosterone in them,
they have
right?
PDE inhibitors and things like that.
Exactly.
That's I've spoken about what to look out for and what's actually legit, and that's kind of what I like to promote: evidence-based, from the evidence that exists, methods of increasing testosterone. All right, so guy with AD, they were on ADT. You wait 6 months. Their testosterone has not risen like they liked or to any normal level. PSA is undetectable. Is that a good candidate for TRT 6 months later?
If they are symptomatic and they have low testosterone, yes. But, I'm saying I'd start them on testosterone. But, I just want to clarify that for me, that also could mean starting someone on something called Clomid, or clomiphene citrate, which is a selective estrogen
Right.
receptor modulator that blocks estrogen to the receptors, which stimulates their
Right.
own natural testosterone to increase. So I have a lot of patients that are on Clomid as well. So it doesn't necessarily mean that it has to be exogenous testosterone that I
Right.
start them on.
And so what are you looking for to determine whether they come off or not? So this, I guess, and that's a, as best as I know, that's a gray area. Some people would say only until I see something on an image will I take them off. I won't look, PSA will not be that determining factor, right? Only until PSMA
Yeah,
scan
PSA
or, yeah.
alone, no.
So what are you looking for? So again, patient, advanced disease, they were on ADT, they're off 6 months or 12 months after. You have them on TRT. In what scenario would you take them off?
Again, it would usually be in the setting of we start to see something, right? Rising PSA is usually the first thing. Once you get a rising PSA, I'd send them back to their urologic oncologist. And once, they usually will order a PMSA or an MRI, or maybe we need to take a look about this and that. And then it's a decision between all of us. So is there going to be another therapy, right? If they were just a radical prostatectomy, are they going to start radiation therapy? If they're going to start radiation therapy or another treatment, absolutely. We stop that testosterone 100%, I would. If they've had a discussion with their, either radiation therapy or urologist who's managing their prostate cancer, and there's like, what? I don't want anything else. I don't want any other treatment. I don't want this. I don't want that. And they want to stay on testosterone therapy. Then after we've had a long discussion about it with everyone involved and the patient, then I will keep them on it. Again,
Despite
because
their
I'm just a
PSA
big
elevation.
proponent, and I follow them very closely. Like the patient I was mentioning you previously, he's had continually rising PSA. It's still low, but it's every time I see him,
With
it's
bone
continually
metastasis.
going up.
Oh, he
He
doesn't.
does
Okay.
not have bone mets. He does not have bone mets. No, he's had a recent imaging. And so I will give him, I follow him very closely every 3 months. If they have a history of prostate cancer, I get repeat labs and I follow them every 3 months. And we kind of go from there and we make a decision. We talk about it every
Patient
visit.
with bone metastasis? What would you do?
I don't know. I might not. I luckily haven't had that
Oh,
patient yet.
they're coming.
I
They're
think I'd
coming
have a hard
now. After
time
this episode is
because I
published,
know,
they're
right?
coming now. They're looking. They're gonna look for you.
Because what you worry about in that case is you worry about them developing fractures and pain. And so that would, that would have to be a really big discussion that you take with everyone involved in their care.
I tell you, I have them weight lift. I have my bone mets patients weight lift. Tell them to be careful. I tell them to,
Good.
but I have not seen evidence, case reports, or in my experience on anyone with bone mets fracture a bone yet, at least with the recommendations. And there's a group out of Australia that publishes on prostate cancer and exercise and weight resistant exercise. They've looked at men with bone mets and they've have them do weight resistant training, and they have not seen yet anyone fracture a bone. So, yep.
That's great. That's great. We know that hypogonadism as well, right?
Absolutely.
Leads to osteoporosis.
Absolutely. So maybe that even helps. Maybe some reversal of bone strength. If not, BAT, bipolar androgen therapy, that's fascinating. That will continue to fascinate me. There's not a lot of people doing this kind of research, as someone once told me, look, there's very little to gain and a lot to lose, right? So you're seeing patients as a routine visit. There's no procedure, and you have something to lose if studies show or that they progress with their prostate cancer, then you have more to lose than to gain. So that's the reason. But I think that patients would do, if we were to theorize for a second, patients would do really well. You've seen it with advanced prostate cancer and having their testosterone. They do care about their quality of life quite a bit. They do.
Absolutely.
And I think we need to honor that more as opposed to, quantity versus quality. As you mentioned, quality matters a lot. We know that. They say that. But man, I wonder, there's probably more quantity there too. There's probably more quantity there as well. They live longer.
Yeah. No, you bring up a really good point. Very good point.
Helen, final thoughts before you go to your boys for the rest of the evening. Before you go to your next shift, taking care of, and not only 3 boys, there's 4 boys. But I tell my wife, you have 4 kids. You have 2 boys and 2 girls, and I'm one of those boys. So, any final thoughts?
No, I'm so glad you had this podcast because I think this is really an area that there's a lot of misinformation. People are still practicing from very outdated recommendations or old data that's been disproven or debunked. And, again, we have a large study that we're doing at Indiana University right now as well. It's a retrospective study looking at all of our radical prostatectomy patients. And, we haven't final published it yet, but we're seeing the exact same thing and men that have a history of prostate cancer that have low testosterone, when you give them give them testosterone, it's not promoting earlier or biochemical recurrence in these men any more than same exact patients with prostate cancer that we're not treating. So I just think at this point in time, everyone should familiarize yourself with the data, read the guidelines that we have on it. There's the American Urological Association guidelines on this as well, and understand that, again, PSA is an androgen-dependent process. By giving testosterone, we are not creating prostate cancer, and that we really should be considering this in men that are extremely symptomatic. Just because they have a history of prostate cancer shouldn't exclude them from being able to have a medication that can dramatically improve their quality of life and their overall health, as evidenced by the Traverse study and many other studies that show that testosterone is important for overall health, for cardiac health, for stroke prevention, for prevention of diabetes and osteoporosis. So again, I just think that we shouldn't have this black box X of, testosterone, prostate cancer, no way. We really need to be a little bit more cognizant, educate ourselves, and give patients the opportunity to improve not only their quality of life, but their overall
I love it.
health.
Where can people find you?
I am at Indiana University.
Who's your town?
And I'm also, yes, even though I'm still a Roll Tide person. Right? But no, and I'm also on social media. You can find me at Dr. Helen Bernie. I have an active Twitter and Instagram account. But yeah, I'm always happy to help, and I do webinars. And thanks so much for having me on this podcast.
Helen, it's my pleasure,
really
and I will link you up in our notes to your handle, Twitter handle. I'm sorry, X handle. Come on, we're at X now.
That's right.
And I'll link it up to your website and different ways to find you. Thank you so much for being on, Helen. So grateful that you made time for this. I really appreciate you.
Thank you so much for the invitation and bringing up such an important topic for our patients.
Yep. Thank you. All right, everyone. Thank you for listening. Thank you for viewing. This is Dr. Gio signing off. I'll talk to you next time. Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Gio Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.